Okay, we're recording, so it's 1400, and I'll go ahead and get started, but I'll go slowly to let a few more people have a chance to get in before you start presenting. I'm Bob Wolverton. I'm the Program Director for the Northwest Regional Telehealth Resource Center. As many of you know, we represent a 12-state region ranging from Wyoming in the east, which sounds kind of odd, to Alaska in the west. And this is another one of our series of monthly webinars. Today we'll have some discussion about how to work with payers. The next webinar we have coming up is in May 30th, with Dr. Jeffrey Saffel of the Utah Burn Center. And they've been doing a lot of teleburn work lately, so Dr. Saffel is going to talk to us about that and about how they're doing teleburn and how to build a network a little bit on that. You'll see on your Adobe Connect board over on the right, you have the list of the presenters and the participants here. On the second module down, you see a module titled Files. On that point, you can download the NRTRC Save the Date postcard for our conference next March in, Portland, Oregon. And you can also download today's PDF of today's slides, Working with Payers. In the bottom right module, you'll see a link. These are web links. You can click on the Take the Survey link to tell us what you think about what we presented today, and to make some suggestions for webinars you'd like to see. You can sign up for our newsletter, which comes out bi-monthly, and you can also link to our conference website. There's a chat module just to the left of that where you can have contact with each other or to everyone. And then all the way on the left is probably the most important module on the bottom. That's the question and answer module. If you have questions for our speakers, you can type your question into there and it will show up. Maybe Joe and Kathy, as you're swapping back and forth, you can take a look at that window. And if you don't have a chance to do that, I'll bring up the questions toward the end of the discussion. So I think we've had enough time to get people signed up. Looks like we've got a pretty good crowd today. So let me introduce our speakers. Dr. Joe Humphry is an internal medicine specialist with an interest in diabetes. He graduated from the University of California, San Francisco, and did his internal medicine residency at the University of Rochester and UCLA. Joe's been a consultant in diabetes and chronic disease management to the Pacific Basin, and he served on a number of state and national committees, including the National Diabetes Education Program. Joe has over 30 years' experience as a safety net provider in community health centers and more than 25 years' experience with health information technology. 12 of those years have been with the University of Hawaii Telehealth Research Institute. Joe's directed telehealth projects in Waianae, Hana, and the Big Island. I'm sorry, I don't speak Hawaiian. And he's just retired after 22 years as medical director at HIMSA, which is the Blue Cross Blue Shield of Hawaii organization. Kathy Britton is our other presenter. Kathy's a co-founder and past president of the Telehealth Alliance of Oregon, and she currently serves as a program director there. She's a principal and owner of C.S. Britton Consulting in Medford, Oregon, and Kathy has served as chair of the TAO Reimbursement Work Group, which is responsible for developing Oregon's telehealth reimbursement legislation in 2009. Kathy also serves on the advisory board for the NRTRC, and Joe is a retired member of the NRTRC board. He split off from us and formed his own TRC a couple of years ago. So with that, I'm going to hand it over to Joe. I believe you're going to start.
Yeah, that's the way we got this planned. And I believe that Bob asked me to do this because of my 22 years with HMSA, which is Blue Cross Blue Shield Hawaii. My life has always been a contrast between a safety net provider and working in corporate America. And when I started there and and worked continuously within the health plan, it was always an enlightening experience because I had never envisioned myself working for a large corporation. HMSA, or Blue Cross Blue Shield, here is nonprofit, and it is a very good organization to work for, with a very good mission statement, and they try to live up to that. However, when we are looking at health plans, one of the first things I learned is that they are a business first and a health service provider second. And unlike what I usually do when I am going to somebody within the university or going to a national conference, where I attempt to make evidence-based medicine as sort of my platform on discussing and build a very logical argument. Within the business world, they move much more rapidly as far as how they make decisions, and they use the best available information, which quite often is not based in science. And the best available information often comes from trusted experts or other folks. And so in dealing with health plans, always keep that in mind, because you need to know, who's providing information and how they're providing information to move forward with a strategy that will allow you to have access to them and and be able to develop a cogent discussion with them. And you don't have to spend a lot of time developing a thorough scientific presentation quite often, or our presentation actually relates to cost also. I just mentioned with cost that in the 22 years I was at HMSA, virtually every presentation that we had would often try to convince us that organization was going to save us costs. So when you go in and you think you're going to be able to sell something because it's a great idea, because you're going to save money for the health plan, they hear that from everybody else also. So it doesn't become a very convincing argument unless you have some very compelling and very good financial data. I want Kathy just to briefly see if you have anything else to add to that, Kathy.
No, Joe, I'm good.
You're good. All right. Yeah, the other thing with health plans is to understand that there's decision drivers around the table, and they do not just listen to certain constituents. Telehealth fits in the arena of being providers, providers of service, not clinicians. But the other people that are going to influence whether they move forward with changing policy or changing payment are employers. They're a very critical element to this, because they actually pay the premiums. They pay the majority of the premiums. Subscribers also pay some of that premiums. But I've seen where employers begin to have in their conferences ways of modifying or changing the delivery of health care, that the health plans will rapidly adopt those. So if you have an employer that really likes telehealth, that may be a great partner. The pharmaceutical industry, has a tremendous influence on health plans because of rebates and discounts and the huge budget that they have. Physicians do have influence, but because of the fact that most physician groups are small, that influence is not very great in regards both to how much they get paid as well as how they develop policy, unless they are very well organized. But certainly individual providers don't. The large physician groups certainly can play a role. Hospitals and other institutions play a much more significant role. And certainly here in Hawaii, where we've got a hospital consortium of 4 hospitals that is beginning to get large enough that they can somewhat dictate the market when they come up to negotiate with HMSA every 4 years. And then if it's a for-profit operation, obviously stockholders become a major player also. And so you have to understand the relationship with stockholders. And for nonprofits such as HMSA, there is a volunteer board of directors. And to understand the health plan, it's often good to talk with somebody that's in the board of directors, because they have a different perspective on how the health plan runs. They do not make day-to-day decisions, so the board of directors is not exactly the best access in regards to getting them to change policy. But they do, but they can give you a lot of insight on how the actual health plan runs if you have some relationship to one of the board of directors, and are usually pretty open to discuss concepts and ideas related to health. Kathy, do you have anything else to add there?
No, thanks, Joe.
Nope. Oh, good. Yeah, the other important piece that that I often is sort of overlooked is where the money is. Telehealth as an individual service, it often actually increases rather than decreases cost. Reimbursement for telehealth consultations have a little additional cost for the site of origin, and even with that, why the way that Medicare reimburses is often a break even or losing venture unless there's some cost shift in the overall dollar amount. And so in going to present, why you have to understand where there's potential cost savings. And I put this slide up because every health plan is a little bit different, but 40% of your money is going into the hospital. If you've got very good evidence that you can reduce either hospital stays or length of stays in the hospital by providing better specialty consultation to be able to shorten length of stay, etc., that's sort of low-hanging fruit. If you're going to be dealing with a great solution to providing home health but has no influence on the hospital stays, you're not in an area where there's going to be a lot of cost savings, because it's down in that other 10% other that particularly the non-Medicare population or the private pay home health services are very, very small percentage of the budget. So when you're looking at the telehealth services you're providing, you've got to keep in mind where those additional cost savings are. Otherwise, the health plan's not going to be particularly excited about just paying for consultations on their own. Any other comment there, Kathy?
No, Joe, thank you.
All right, and I'm gonna pass the baton over to Kathy and let her discuss some of the things that have happened in Oregon and other ways of approaching folks. Go ahead, Kathy.
Thank you. When you work with payers, there's normally two kinds of approaches, and we're seeing both happening, and much more so we're seeing more of a regulatory legislative approach than we used to, because we're now seeing some success with that. And so we're seeing more and more states passing bills that require payers to reimburse for telemedicine. Montana, I don't know how far you are through your process, but you're very close, if not finished. But both approaches are important for you from the standpoint that you need to look at what do you want, and how are you going to get it, and how can you best get it. Both approaches require that the payers be included in the discussions. A lot of times we think that we can resolve the regulatory legislative problems by excluding the payers and just mandating what they'll do. And let me tell you, that backfires real fast. There's all kinds of ways that payers can use to make sure that those rules don't get written, or the rules get written differently than the legislative intent was. And so one of the things I want to stress with this is, no matter which way you go here, be sure that you are very inclusive when you start working with payers. If you're going to work with them as a group, be sure that you have a table that includes them, that you've established some ground rules for what the discussions are going to be, and that you level the playing field as much as possible. If you are going to be negotiating with an individual payer in a region like Joe has done in Hawaii, you want to make sure that that payer knows what you want from them, and that they understand what it is that you're asking them to pay for. We found out in Oregon that there's a lot of ignorance on both sides. We were very ignorant of insurance as telemedicine providers, and the payers were pretty ignorant of telemedicine and what it entailed. And so one of the reasons that it's important to be inclusive in your planning and your discussions is to make sure that everybody understands who is doing what, who is paying for what, how it gets paid for, who governs, who makes the rules, and then what it is exactly that we're talking about in terms of the telemedicine service. Both approaches can address telehealth services in general, or they can address specific services depending on what your need is. There's also right now two very different environments going on, and it used to be that we worked mainly in a fee-for-service environment, and the payer paid for each service that was delivered regardless of outcome. If it was on the list of services that were paid for and you submitted the bill, then that was paid for. The rules, however, were very prescriptive regarding the services, and there was very little leeway outside of those prescribed services. And at this point in time, we still are looking at that approach very much in the CMS environment, although we are going to begin to see that change. They're also very prescriptive in terms of how they are delivered and where they can be delivered. So the world is going to, I think, change dramatically going forward. And I like to think that Oregon takes a leadership role sometimes in healthcare. I think we're very fortunate in that we have a governor who is an emergency room physician, who was the author of the Oregon Health Plan when he was in the legislature, and who is very concerned about bankrupting the state of Oregon with our healthcare costs. And so he's worked really hard to come up with a different way to do to provide payment for healthcare and to provide healthcare services. In the old environment, we often called this approach managed care. And managed care is probably still an appropriate term, but the connotation is bad because we did not hold those who were managing the care accountable for the outcomes of the health, for the health of the patients or for the health of the community. It was very often they were given a per member amount, and they could use that amount in whatever way they wanted to, but they weren't always required to show that they had improved the health of their patients or their community. The good thing about an accountable care model, which is what Medicare is calling their new model, and coordinated care models, which is what Oregon is calling its Medicaid model, is that it does not limit services. There's still a per member amount paid to the coordinated care organization, but the difference is that regardless of how they deliver those services or which services they deliver or who is used to deliver those services, they must focus on the coordination of care, and they must focus on the outcomes for their patients. And if they don't deliver those outcomes for the patients in the communities, they don't get paid. So I think that this new environment really is going to encourage the use of telemedicine. It'll be one way to deliver what they need to deliver in order to make the outcomes appropriate, but it will also allow them to do it in a manner that is not terribly expensive. What we'd like to do now, Joe, I haven't asked you if you want to comment. I'm sorry.
Yeah, I would have just one comment, because the payment systems are so distinctly different, and we're so used to the fee-for-service that everybody wants to go in and get their service paid for, in the fee-for-service arena, by adding a CPT code or by making it linked to a CPT code. The current literature or current information coming over the web in the last 2 to 3 months is that the fee-for-service payment system will no longer be in place in 5 years. So as you think about telehealth, you clearly have to be thinking about the future, not now, because it takes a long time to work with health plans, and trying to go in and get your service paid for in a fee-for-service arena will probably, once you get it done, well, it will probably no longer be relevant. So the value-based payment is very critical. The other piece is linked services versus the cost silos. And we've got pharmacy benefit management that just handles drugs, and they often will save money by giving out the least expensive medication or making it difficult to get more expensive medications. However, sometimes those more expensive medications will save ER visits or hospitalizations that the more effective drug would not be paid for. In a pharmacy benefit management, they save money by saving money on drugs, whereas if we have linked services where there's an advantage of combining, and that's where telehealth sits, is that if you do telehealth and do a good job with home monitoring, that the accountable care organization will see a reduced number of hospitalizations, so that the activities for telehealth may be more expensive, but there's cost savings elsewhere. And figuring those things out going forward are real critical, basically to add to what Kathy said.
Thanks, Joe. I appreciate that. I think that the linked services are what we will begin to see more and more, and certainly is what is the basis for the coordinated care organizations in Oregon. We'd like to talk to you now about some tips that we have garnered, some of them the hard way and some of them not so hard, but for working with payers over the years. And there's no magic bullet. There's nothing that's guaranteed to work, and there's nothing that says that this is a limited list. But these are the things that we found most valuable as we went through the process of working with payers to get payment for telemedicine. The first thing, I alluded to this earlier, is know how health insurance is regulated in your state, who makes the rules and who is affected. And we all know that Medicare is not something that is a state process. However, you still need to know how Medicare pays for services and what those rules are and how those rules get changed and what you need to do if you want to make a change to those rules. I also think that we will begin to see waivers come in from states if they have a successful accountable care or coordinated care model in their state, to take over the Medicare services under the coordinated or accountable care models that they've developed. So it'll be even more important that you understand what the terms of that waiver might be and how that is going to affect the payment regulations in that in your state. It's very important that you understand who regulates private payers versus who regulates Medicaid payers versus who regulates personal health plans. And it's different in every state. So we were very, very surprised to learn how the process worked in Oregon, and that you couldn't, if you were going to write legislation, you couldn't just write a blanket piece of legislation that covered all the different kinds of payers and the rules that governed them, that you really had to stop and sort it out. The second thing that we stressed was that you needed to educate health plans about telemedicine, and don't ever assume that they understand how services are provided using telemedicine or what the costs are for each. I had a payer say to me, well, we don't need to pay as much for services delivered telemedically because the doctor doesn't have to have all this equipment in his office, and he doesn't really even need to have an office. So what are we paying him for? And I had to laugh because there was a real lack of understanding about what went on in a telemedicine provided service. And so we literally took payers and pulled them into actual telemedicine consults so that they could see what those looked like, or to see what any kind of a telemedicine service looked like, how it functioned. And that really, really seemed to be a leveler in terms of how we were able to work with them. So I think it's both sides of the coin. Know how the health insurance is regulated in your state, and make sure that health plans know about telemedicine. Joe, comments?
No, I don't have anything further. I guess I get the next slide, though.
Yes, you do.
Moving forward. I think following on what Kathy's saying is that I've been surprised at times when people have come to the health plan and have wanted to get the health plan to pay for something, and we're already paying for it. And it is sometimes challenging to decide how and what is paid for by a health plan without actually submitting a bill. But it is worthwhile, as you begin to understand the health plans, ask very specific things in relationship to services on what is covered. I would make a comment here, and something we ran into with HMSA after I had my retirement, and that is that we were very forward. HMSA was very forward with telehealth, and actually had a telehealth policy covering telehealth prior to the 2002 Medicare ruling coming out. That we had a vice president that was very forward-thinking, and so telehealth has been covered by the health plan here for more than 10 years. However, there's two different things. There's a policy on what is covered, and then the health plans also have a payment policy, and that is how much they pay for the service. And we were looking at Telederm, which Hawaii and Alaska have the Medicare benefit for store and forward consultations. So that's been in existence, and Medicare covers store and forward in our two states. And HMSA essentially adopted the Medicare regulations for their policy. However, when it came to Telederm, similar to what Kathy was saying, they said, well, this is such simple technology that we're going to only pay a very little bit of the actual consultation costs. So you've got to be aware of the fact that you've got a policy on what is covered, but the health plan also can determine what the copay is and what the total cost of every service. That's the eligible fee in health plan terminology. The second is that we already have some things that are bundled services. The DRG, home health, and long-term care are all bundled services. You need to understand the payment system because often telehealth services, like if it's in a long-term care facility, they already are getting a bundled payment, and you may be adding cost on top of that. If it's consultative services, why that can be billed on the provider standpoint, but if it was a remote monitoring system for a long-term care facility or home health agency, that would not come from the health plan, but would come out of the home health bundled payments. And so you have to figure out where that is, and trying to convince a health plan to pay for something where there's a bundled service like a DRG is a very, very steep road to go up. Once you get that bundled service, the health plan absolutely wants to keep everything bundled and not start paying piecemeal for various different services. There are some exceptions to that. I know that some high-cost drugs and other things, I think, intravenous feedings and things can be added on top of a bundled service because they are so exceptionally expensive. But it is a very rough road to travel if you're going to have your telehealth covered by the by the health plan when it is a bundled service. And moving forward, I'm getting back that original slide, and that is the is that those decisions by the health plan are based on best available information, but they also are focused on on pleasing the stakeholders. And that second slide was with all the stakeholders. If you partner with other stakeholders, then obviously you might have a better chance of talking with the health plan than if you go in just as a telehealth provider. So knowing what employers might be interested in, and if you've got an employer or a union group that is very excited about telehealth, that may be a very, very strong ally because it's outside of the provider realm. And if both of you are approaching it, you may have a lot more success than if you go in and try to talk to them individually. So figuring out where those other stakeholders are very critical. Successful programs have often been developed around hospitals and the need for hospitals to get increased numbers of patients into their institution. So those are other good partners. And I've learned with the business decisions, evidence-based medicine often is not well understood by health plan executives, the people that actually make the decisions. Having that relationship for a long time with the health plan really helps, and also telling a good story, so that I think some of the videos that have come out have been very, very effective to be able to bring people to understand what telehealth is. Kathy said, having them go out and actually see consultations and see the rewards. It's always great to have pediatrics involved because that gets a lot more attention than taking care of elderly people in their houses sometimes. And you also want to be able to look at the downside, that they do not want to fund projects that are going to be significantly or add increased cost, and they don't understand what the cost structure is. So that they are conservative organizations, and so you have to have some of the financials well worked out. And certainly if you have experience with other organizations that can show that there will be improved care and cost. And I would stress in this day and age with the value-based payments that health plans are very interested in getting increased quality to their members. That is important to employers. It really translates into keeping people working rather than sick. And so, keep in mind that it's not just the dollars and cents anymore. And the health plans all are required to be NCQA certified and measure HEDIS measurements. So if you can improve those metrics through telehealth, then that's probably actually a better way of approaching it than the cost savings. Anything else, Kathy?
No, I just wanted to emphasize, bringing the stakeholders into the discussion. One of the strongest advocates in Oregon for many years for telemedicine was the Public Employees Benefit Board. They were very, very interested in seeing that their members got telemedicine and got services via telemedicine, and they were very strong advocates, particularly in the legislature. So it's important to look around and see who the stakeholders are in your state and who are the strong stakeholders, and spend some time with them and educate them. And a lot of times that will come back to you in terms of some really strong support. For emerging ACOs and CCOs, evidence is of critical importance. At our Tau Summit a couple of weeks ago, we listened to a woman who was from one of the very large CCOs in Oregon, and who has a whole lifetime of experience in terms of healthcare payment. And she said that coming into a CCO or an ACO where the outcomes requirements loom so large that if you do not have evidence in hand to show that you can help them achieve those outcomes, they're going to show you the door. They don't want you to say, well, gee, we think this will do. We think this will work. They want you to say, this has been tried, and in this number of patients, this is how the outcome was changed. And they want you to be able to push what you're offering past the pilot phase. They want some very concrete data. And as Joe mentioned earlier, you need to know what those metrics are for their performance. In Oregon, there's a very defined list, and you can go to the website and you can see exactly what they have to achieve in terms of those metrics, and what they have to accomplish before they're going to continue to get their funds. And so it's really important that you educate yourself about those metrics, and look for the niche that you can fit into, not just blanket hit them with, oh, telemedicine is the greatest thing since sliced bread, for any kind of service that you might want to deliver. They may not need all those services. They may need retinopathy checks for folks with diabetes. They may need dental checks or dental follow-ups for pediatric patients. Know what it is that they need. And don't ever try to sell telemedicine as a means to reduce costs. They played that game so much better than we do. It's ludicrous. It does not necessarily reduce cost, but it very definitely, you could show them that it improves outcomes and reduces their risk. So do not come at it from the approach of reducing costs, because overall it is not going to reduce their costs. So do you have anything to add?
No, I think that's good. Yeah, further tips. Good ideas brought by individuals or by one organization are often dead on arrival at health plans. There are an awful lot of folks that decide to go to the health plan rather than going to their colleagues or going to the community and figuring out who else is interested in doing the same thing or promoting the same thing. And so it's very helpful to have, if it's a telehealth issues, to have everybody in the state that's involved in telehealth supporting you, because the last thing you need to do is have somebody stand up and that's it should be one of your constituents and say, oh, I don't think that's going to work, because the health plan is going to back off very quickly. So you have to really know your community well, as we talked about before, getting union groups, getting employers, getting subscribers or patients that have had great experiences with telehealth, build that story. But as you approach the health plan, it just is so much easier if you've got several people with different perspectives, all arguing for the same service or the same solution, and the health plan is much more likely to listen to you. Also there are a lot of telehealth vendors out there, so it's definitely not the first time they've heard about telehealth, because there's often a desire for somebody to sell something to them, and so generally speaking, certainly as telehealth resource centers, we're much more educational and looking for solutions rather than looking for a sale. And then look at where they might be already providing services, and look for where you can fill in the gap. One of the areas here in Hawaii that has been a real issue is that our health plan basically contracted with American Wells, which is a web-based consultative services that the idea was similar to what Kathy was saying. American Wells allowed doctors to do consultations from their home over their computers with video conferencing or text messaging for a 10-minute consultation. And because the health plan's invested in that, and it's a contracted service, it gets to be really problematic going in trying to sell the health plan on other services that are similar for teleconsultation without using the systems that they've already put in place. So you really do have to find out what they currently have, and if you're trying to duplicate services, you're going to have a battle. You really need to try to fill in gaps in care where where you'll provide a better option. And the other thing is to look at where there's existing relationships, excuse me, and that means find out who's been to the health plan before and who's been successful. And quite often you can look at the hospitals who have had negotiations with the health plan, understand the higher structures of the health plan by talking with people that have previously had successful negotiations with the with the health plan, and what strategies they've used in your local market or your local environment. And also with using people like that, make sure they're well on board with what you're doing, because they've got the relationship. If indeed you use their name, or if they go with you but they don't completely understand why you're there, why it very easily could backfire. So you may need to make sure that they're well prepared prior to walking in. Because I've been a medical director, I have used my influence to talk to other medical directors. You can approach the health plan by going through and trying to talk to the executives, or you can approach the health plan by seeing if you can get support from the clinical services. And the medical directors are clinicians, and they often can see the value of telehealth better than an executive who's always concerned, a chief financial officer who's always concerned primarily related to the money issues. And so if you have physicians in the community that can talk to the medical director at your health plan and begin to build that relationship, have the medical director provide information and recommendations on how to structure your presentation. And I have indeed helped people to gain access to the health plan, and even if it's something I don't particularly believe in, I at least give them the shot of better organizing the way that they're going to present things, so that it can be seriously considered by the health plan, because there's just so many different people approaching health plans that if you don't have that piece in place, why you're not going to be successful at getting the attention. And I think there are a number of really good ideas that get lost by health plans just because of the way that the individual or the group actually approaches a health plan. There again, I think we've emphasized this, but you have to understand what the upside liability is for the health plan. I've seen 2 telehealth-like services just go crazy here in Hawaii. One was the office echocardiogram, a company that basically took a small echocardiogram machine into the primary care providers, and we saw an increase in echocardiograms from having ordered 2 or 3 a year to having ordered over 100 a year in primary care practices, with no real control on those issues. So and the quality of those echoes was dismally poor. The reports all came back with the cardiologist saying poor quality echo, but then they'd go ahead and charge for the service anyhow without any concern with quality. So, and the other one was nerve conduction studies in the primary care setting, where it was a store and forward, and it'd go back and get a computer readout of what the nerve conduction was. The primary care doctor would sign off on it. It did not involve true nerve conduction. It was a fairly good technology, but didn't give you as much accuracy as nerve conductions done by a neurologist or a physiatrist. And there again, very, very very high volume in the primary care setting, testing virtually everybody with diabetes. So if you've got something where there's no way of controlling the utilization, and it gets and it's coded back to something like the nerve conductions using the standard CPT codes, why there was a lot of leftover money for everybody to split up when you could do a nerve conduction in 10 minutes instead of 45. So I hope you appreciate when you're going in there to look at where those upside liabilities are. And with that, why you really need to think about how to do standards credentialing. We're involved in teleophthalmology, or I've just recently seen everybody taking a picture and sending it via cell phone, and yet the ATA has very standard methods to get excellent pictures and train the person who's the primary care site or the site of origin to be able to get an adequate picture, so you don't force your consultant to be looking at something that is not well standardized and follows existing guidelines. You may also want to talk to them about credentialing and criteria for utilization, when the procedure or when the consult should be used, so that you can address those issues of overutilization. Sometimes you'll be offered a pilot, but it would be much better if you really could believe what you're doing is the correct things. A small pilot often lasts 2 to 3 years, and the rest of the industry is going to pass you by the time you get that done. And I've seen a number. We had a telehealth home health pilot that HMSA funded 50 people with the provider, assuming that we were going to collect good data, which never happened because it just was not well organized. They're not a research organization, and the outcome of the pilot never showed anything because the data wasn't available. So that's an issue or problem with pilots. So if you believe what you're doing, why it should be used across all the members. And then, finally, you do need to spend a lot of time with your business model, and I think that would be self-evident at this point. And if you have data, either your own or other data, with utilization and how this works, and the cost trade-off, as we've mentioned, with potentially other services. The other thing that I would emphasize is that you want to price your services appropriate. If you can show where the costs are, which is a rarity in healthcare. You can't go to a hospital and ask them how they figured out what a lab test cost. But if you've got that down, that's going to impress the payers considerably, and how they look at you because you've done your homework.
Hey,
I think did I steal one from you, Kathy?
Hey, you can steal anything you want from me, Joe. Do want to stress that the time for offering pilots is not when you're trying to sell a service to a healthcare organization. You want to have a well-developed service with some well-developed data, and I think that's important. If we're trying to sell ourselves as a industry that is going and has good data and is ready to help save them money and improve their access and help them achieve the outcomes that they need, then you can't say, well, we think this might be the way that it happens. So if you need to do a pilot, find a different way to do a pilot than trying to inject that service into somebody's business model. The final piece of advice that we have for you is you're going to get rejected. I mean, that goes without saying, and not always and not for everything, but you are going to have some rejection. And just because you are rejected doesn't mean that your relationship with that healthcare provider or health plan provider is over. You need to keep them in the discussions about telemedicine. You need to keep inviting them to your conferences, to new developments in telemedicine. Maybe offer a webinar to the health plans on some new aspects of telemedicine. But just keep putting it out there and keep talking to them, keep encouraging them to look at things. And you never know. At some point, when they're ready and when it fits what they want to do, they may come to you and say, we appreciate that you've stuck with us all this time. We'd really like to go forward with this now. Can you help us? And that's a very, very rewarding situation to find yourself in, because you know that the work that you've done has paid off and that the buy-in is going to be 100% because they are coming to you and asking you to help with that service. So continue those relationships and keep the information flowing. That's what we have to offer you. Joe, do you have any last comments, or should we ask people if they have questions? Our little Q&A thing is empty unless my Q&A thing doesn't work.
Yeah, I had one other comment, and that is that it often does help if you don't have local resources to take somebody that has a successful program with you in talking with the health plan, and I just recently got a request for remote monitoring for blood glucose monitoring. That there was some resistance back at Massachusetts Blue Cross Blue Shield, or whatever the name of the Massachusetts Blue Cross Blue Shield is. And as a former medical director, I probably would be able to get access to one of the medical directors there. And I wouldn't try to sell them on remote monitoring. I could basically ask them, where are the barriers? What is creating the fact that this type of technology would not be would not it would not be accepted by Blue Cross Blue Shield. You know, what other information do you need, and how can we provide? How can the people back in Massachusetts provide it? But yeah, having outside people that are connected in the health plan, so one health plan talking to another, one medical director talking to another, may also help to break the ice and give you access, or at least an understanding of the internal part. I was fairly ineffective inside the health plan because I was, was an employee, and so even if I brought the best evidence, why I often got some resistance, and there would be barriers to problem solve. So even if you got the medical director on your side, that doesn't mean that the execs are going to go and follow along with that. And we'll see if we can open up for questions. I saw that Bob. Yeah, I don't know if the Q&A is not working, or we're so good and we have everybody in awe that they have no questions.
Well, you've got me in awe, that's for sure.
Either that or they all went to sleep, Joe.
Yeah, right. Well, I'm not going to comment on Bob's.
Here we go. Tara asks, have you had experience when trying to get reimbursement for addiction treatment services?
I'll take a crack at that. One of the things that is going to happen in the CCO models in Oregon is that each CCO must provide primary care, mental health care, and addiction services care to every patient that needs it. And so as a result of that, if they choose to, they can very much pay for addiction treatment services that are delivered telemedically. Will they? I don't know. But again, what I want to stress is that as these models evolve away from fee-for-service and into the coordinated care where the outcomes are really the key to payment, then I think you'll find a little easier time of getting payment for addiction treatment. I know that's not exactly the answer you probably wanted to hear, but I think that's, if we're talking about moving away from how we work with the present models and into how we work with the future models, then I think that's certainly something that we're going to see payment for.
Yeah, and I think this is a great place to look at new payment models where there's value-based payment. I have a fair amount of experience with addiction medicine being a safety net provider. Even though I try to see patients with diabetes, it's often mixed with addiction problems. And the expertise in really having effective programs are really concentrated in the urban settings. And so the argument there would not be a single consultation, but to try to integrate the expert with the distant site. And so I think you could mount a very good argument that this would be one of the first places, just like behavioral health and pediatric behavioral health here in Hawaii is one of our major services, because we have everything concentrated on Oahu, and we can convince the payers that it makes a lot of sense to expand that expertise to neighbor islands without having to have somebody trained in the neighbor islands. So it would be my other comment on that.
One last thought is that I think it will be interesting to see if we cannot create contracts with the new models, the new providers of the new under the new models, to pay for the echo type approach to addiction treatment services, particularly for rural areas, because it has been so successful in many instances. And I think that if you're looking at being able to get a lot of bang for your buck, I think paying for a contract for an eco-type model or an eco-type project in a rural area would be one of the ways that you might get payment for the addiction treatment services.
Okay, as we're just about to wrap up here, we'll wait for a few more comments, and as we do, I will take this thing off my screen. I hope that didn't beep at you. I'll remind you that in the bottom right corner column here, we have an opportunity to link on a survey that you can tell us what you thought about the presentation and what you'd like to see coming up in the future. You can sign up for our newsletter, and you can get a little bit more information about next year's conference on these 3 web links. And if you want to see download the slides for your memory refreshers, you can click on the Files module, and Working with Payers is the slides from today's show, and the NRTRC Save the Date postcard to remind you that we're having our conference in Portland, Oregon next year. And I don't see any more questions coming in. Just remind your friends and neighbors that you can review this presentation. It will be uploaded to our website as soon as we get it all compiled, and you can see this again and again and again. So again, I want to extend my thanks to Kathy and Joe for their presentation. I think they gave us all something to think about, and I want to thank all of you who've come in to attend for being here. So thank you very much.